Great. Hi, everyone. You're very welcome to the third Raindrop Rare Disease webinar today, which will focus on living with a rare disease. We have an excellent group of speakers today who are all experts through experience of living with rare diseases. So Julie Power is our first speaker then. So Julie is the founder and patient contact for Vasculitis Ireland Awareness, and she'll be discussing day-to-day challenges of living with rare illness. Our next speaker then will be Anne Lawlor. And Anne is a founding member of the 22q11 Ireland support group, which supports families affected by 22q deletion syndrome. And she'll discuss life as a rare parent, as a person of a person with a child who has a rare disease. Our third speaker then is Les Martin. Les is a newborn screening advocate, and he'll discuss the importance of the expansion of the newborn screening programme in Ireland. And then Aisling will be our final speaker. So as I said, Aisling is a representative of Rare Ireland and will address both common and unique challenges that children and families experience while living with rare chromosomal disorders in Ireland. So each of our speakers will speak for about 10 minutes. And then we'll have a panel discussion with all speakers, which will be chaired by Avril Daly. At this point, we'll welcome questions from attendees, which you can put into the chat box throughout the seminar. So great. So I'll hand over to Julie first.
Thank you very much for the opportunity to talk here today. My name is Julie. I'm a wife and a mother, and in 2005 I was diagnosed with Wegener's granulomatosis vasculitis. This is a rare autoimmune systemic disease where basically the immune system attacks the blood vessels. So you can appreciate that with the delayed diagnosis or delayed access to treatment, there can be irreversible organ damage. I had been unwell for several years with strange sinus and kidney infections, random blood nosebleeds, flu-like symptoms that came and went, and gradually I started to lose my independence, finding basic skills like dressing or going up and down stairs increasingly painful. Visits to my GP saw no reason for these symptoms. It got to the stage that I was convinced I must be imagining the pain I was in. I attended an ENT specialist who assured me he was an expert in all things ENT. And when my symptoms returned after surgery, he put me on a waiting list for an MRI. When I eventually had this scan, I now realise the results showed classic vasculitis presentation. But because my consultant was not looking for this, he recommended another surgery which relieved the symptoms for a short while. I tell you all this because this is only part of the story that many people with rare disease will tell you about their diagnostic odyssey. We now know that people have waited many years for a diagnosis, and this delay can result in irreversible organ damage. Being diagnosed with Wegener's granulomatosis has been life-changing not only for me, but for my family. Our roles reversed, where my children were looking after me instead of me looking after them. I could not return to work, and this impacted us financially and completely changed any plans we had for our children's education, our future, and our retirement. Paying our bills and mortgage fell onto my husband. Day-to-day life became very different as we adjusted to my new diagnosis. Even the name of what was wrong with me was difficult to get used to. I was diagnosed with Wegener's granulomatosis vasculitis. But then a few years after I was diagnosed, they decided to change the name because Wegener was a consultant involved in the concentration camps, and it wasn't politically correct to have a disease named after him. So they changed it to granulomatosis with polyangiitis vasculitis. So it took me another few years to learn that one. I still see people's eyes glaze over before I finished saying granulomatosis, never mind the polyangiitis vasculitis that completes the name of my condition. There is a picture that a lupus support group use that I relate to and often use when I talk about living with a rare disease. It's of an iceberg. On the surface, I appear to manage getting about and attending to everyday life, enjoying myself, and I even look well. Beneath the surface lies my fatigue, my pain managed with painkillers, fluctuating blood pressure, and I have cardiac, respiratory, and nephrology symptoms. I have difficulty concentrating and I have brain fog. I have reduced hearing, which makes me seem aloof when I'm in company, because there are only so many times you can ask someone to repeat themselves. My inability to follow conversations when I'm tired make me self-conscious of appearing inattentive. The drugs I take all have side effects which impact me. There are many hospital and clinic appointments to attend, regular blood tests, lots of different disciplines, ENT, nephrology, rheumatology, cardiology, dermatology, gynecology are regularly in my calendar, and these can be physically and mentally draining. The psychological impact of these issues have on my family and me have been difficult. What used to be me is now very different. My appearance has changed. I have gained weight. I have hair loss. I'm unable to wear makeup. Prior to surgery, I had a collapsed nose. I no longer recognize myself in the mirror. Things I used to do naturally now take a lot of planning or are impossible. In fact, we did not actually recognize these psychological impacts for a long time, only paying attention to the physical impacts. Being thrust into the world of rare disease where little is known, nothing is certain, to me is like entering a grieving process for lifestyles lost. The isolation and uncertainty impacts the whole family and relationships and needs serious consideration. The psychological and social impact can be as debilitating as many physical symptoms and often impact us all physically. And this needs addressing from diagnosis, just like the physical symptoms. I live with guilt for changing my family's lives and putting extra strain on them. Like recently, my husband had a heart attack, and I wonder, was that part of what the strain that my illness has put on us? But it's all right. We got him early. He didn't need surgery, but we just need another shelf for medication. I have been mostly lucky with the care I have received. I had several consultants who were interested in my condition and who actively sought advice from specialist centres. I wanted to learn more about what I had and to talk to others living with vasculitis. I have learned to listen to my body, recognise the signs and to seek answers. I have also learned that what I know about living with vasculitis is useful to those looking after me, and that together we can manage my condition to maximise my quality of life. I will probably not see a cure, but I will continue to learn how I can manage my disease to the best it can be. I will ask questions, why not, and seek solutions, because the squeaky door hinge gets the oil. So thank you very much for your time.
So I think next then is Anne, if I'm correct, in the new order.
That's correct.
Is that right, Suja?
That's correct.
That's right.
Yeah, okay. So Anne, I'll leave it to Anne Lawlor.
Hi, thanks Emma. Thanks Suja for having me, and hi everyone. I think we all know each other at this stage. That's really interesting listening to Julie, because I think when we listen to each other's stories, we find so many similarities. I mean, I know there's differences, but really there's so many similarities. So I'm going to talk a little bit about my experience as a rare parent, and I'm going to divide the experiences into three kind of significant moments for me as a mother. And they would be before diagnosis, after diagnosis, and then when I found my tribe, because I think those three life-changing kind of sections have brought me to where I am today. So I have a son and a daughter. My son was born first. My daughter Anya was born 5 years later, after a perfectly normal kind of pregnancy. But from the day she was born till the time she was diagnosed at 15, very, very complex care needs and no real direction and no joining of dots, as I call it. When she was 6, she was assessed and I was told she was mildly mentally retarded. Nobody told me what that meant, and nobody pointed me in any kind of direction for her care. And then after all the the medical issues that she faced. She was constantly getting infections and in hospital, globally developmentally delayed, lots of minor disparate symptoms that no one actually joined any dots for me. So it was very difficult, very isolating. And when those kind of medical issues were sort of dealt with, then I was faced with trying to access education for her, because she had learning difficulties and she had behavioral issues and she had emotional mood type of disorders, as they call them. I don't like that word, by the way, disorder. But so that was, and 15, she was in special ed, and the doctor rang me one day and said, there's a new genetic test available. Would you like to have it? It might explain Anya's problems. And I, of course, said yes. I'd like to know what's causing all her issues. So thought no more about it, didn't know anything about genetics, nothing at all. And I was called then into Crumlin Hospital and was given the news that Anya had Di-George syndrome, and Di-George syndrome because of a deletion on her 22nd chromosome. And they were able to find this deletion because of the new test that was available at the time called a FISH test. And again, totally ignorant of any of this. So the diagnosis brought a huge sense of relief, but another equally huge sense of frustration, bewilderment, and where do I go next? Who do I contact? And there was nobody. I was handed a leaflet for a support group in the UK. And I have to say, I'm really sorry that this is 2021 and that's still happening to lots of parents, mostly because of the testing that's advanced so much, because we now have microarrays and whole genome sequencing and exome sequencing. So there's a lot of these type of diagnosis, single gene or deletions, duplications. There's also 22q duplication that are being given out to parents, and there are no appropriate supports also. So this is very concerning to me as a parent, because when I meet, I've got to the stage now where I meet a parent, it's like meeting myself, because it's the same story, and it's concerning to me that this is 2021 and this is still happening. So Anya was 15 at the time. I have to tell you, she's an adult now. She's 37. So I went on in the dark, basically, because there was no Google or Facebook or no way to connect with other parents. I went on in the dark for a good decade later. And then I had the life-changing moment when I found my tribe, because I went to an international conference and I discovered that there were so many parents, there was so much research, there was so much knowledge about this condition, but it was not filtering down to parents. So I eventually set up the 22QR support group, and I've discovered that there are lots and lots of parents like me, lots and lots and lots of them. Individually, these conditions are quite rare. Collectively, when you put them together, we are a huge community. And also I discovered that rare diseases can be ultra rare or common rare. I call 22q deletion syndrome a common rare condition because we're 1 in 2,000, 1 in every 2 to 4,000. So it's a deletion on the 22nd chromosome. It has several missing genes. It's a multi-system condition, and it needs a multi-system approach. It's not like in most cases, it's not life-threatening. We do have some children, unfortunately, who die. Generally, they would be those who have the more serious congenital heart defect, and not all of them have a heart defect or the really compromised immune system. So I suppose I've kind of become known a little bit as the back at the ranch person, because I'm interested in parents and families' daily lives. How do they manage on a daily basis with these complex, and they're often very invisible, like Julie said. You cannot see this on the outside. So the only person who knows the struggle is the person themselves and the family that they live in. So it's really important to me that care pathways are developed and care pathways cross over into educational and social care domains. Julie spoke about the psychological impact. It's the one thing that's missing. It seems to be missing everywhere. There's no psychological support at time of diagnosis. There's no ongoing psychological support, because I find now with Anya as an adult, she needs what I call supervisory care. She's quite independent, but she does need supervisory care. And in speaking to parents of my age, we're all wondering about who's going to do this care coordination when I'm not here. Who's going to look after her? Who's going to make sure that she gets this type of care that she needs? So we're very focused we're a parent organization, we're parent led. We just have a parent committee. We're voluntary. We don't get any funding, but we're working very closely with clinicians, and we have a researcher, and we initiate research. And the research that we look at is in the main psychosocial. It's psychosocial research. How does this affect us as families? What can we do to better the quality of life for our children? And not just as children, but as teenagers, they have to navigate transition into adult care. There is no adult care. As when I say there is no adult care, it's ad hoc. It's kind of disjointed, and there's no speciality in these type of rare diseases that I know of in adult care. So we're working very closely with our families to do that. And you'll hear from Laura or Aisling later. I think the internet has done so much for parents like myself. The Rare Parent Ireland support group now has over 1,000 parents like myself. So like I said, we are individually, we're rare, common rare, ultra rare, whatever we want to call ourselves. But our issues, I have found, are always the same. It's about accessing timely access to care at the point of diagnosis at any time, because as you know, Julie, and you've said, you can be diagnosed anytime. I have 3 families that joined my group this week. One is a brand new newborn baby. One was a 6.5-year-old, and the other has a young adult in their 20s. So it needs to be, the care needs to be there. It needs to be flexible, and it needs to be accessible no matter what age we are. So I would imagine, Emma, I've spoken for 10 minutes, have I? Because I didn't script this, or I didn't prepare any slides. I just wanted to talk in general about life as a rare parent.
No, I think you know the few minutes, because we got going a
Have
little bit earlier.
Oh,
so
excellent.
if you have any more to share, please do.
Oh, Emma, I would talk all day. I would talk all day if I was let. One of the things I suppose that I've become increasingly interested in is the commonality of symptoms. I suppose because I'm not just looking at 22q deletion syndrome anymore. I've discovered that any of these chromosomes can blip. So you get parents getting these very obscure, like 1pq or 1 or 16, you know, because it was really interesting to me to find out that syndromes were generally called after people, and generally males. But now the syndromes are being discovered in the lab. So we're getting a lot of these very single gene conditions or deletions or duplications. But it is interesting to me that the symptoms are so common. So across the deletions and duplications and the mosaicisms and all of that, you would have very, very similar symptoms. And I think we could do well to have a look at that, and maybe that the health services and the social care services and the educational services would realize that these are issues that need to be addressed, and we need to take a holistic view, not just of one condition, but all of the conditions. I'm quite excited about UCD and Suja's research. I'm actually more than excited, I have to say, because this is given great hope to families, to parents like myself, and to families in Ireland, because we have been literally out in the cold for so long in terms of awareness of rare diseases and the issues that we face on a daily basis. So I'd end with that. I think, Emma. I think I've said enough, and just to say thank you again to everybody for listening, and thanks to Suja for spearheading this wonderful project that she's doing, the Raindrop Project.
Great. Thank you very much, Anne. That was really
You're
wonderful.
very welcome.
Okay, so next up is Les Martin. So as I said at the start, Les is a newborn screening advocate, and he's going to discuss the importance of expanding the newborn screening programme in Ireland. So Les,
Now, hi guys, Les Martin is my name. I have two sons who have a disease called Metachromatic Leukodystrophy. It occurs about 1 in 40,000 births, and there's maybe 2 or 3 patients that are born here in Ireland every year. In 2017, I have 3 kids. Holly, my oldest girl, she's 8 now, but our boy Cahill, he was just 2.5 at the time, and he grew up fine until he was 2, but began to sort of miss his kind of milestones. He never really walked alone, and we went through approximately an 18-month diagnostic sort of odyssey with him, in and out of the hospitals, wondering what was the matter. And eventually, from genetic testing that we waited a long time for, he was diagnosed with MLD, which is a terminal disease. It's a neurodegenerative type disease, a metabolic condition, but basically it means that the boys are missing just a simple enzyme, and the absence of that enzyme causes the white matter in the brain to break down, and the myelin sheath around the nerves to break down. And unfortunately for Cahill, at the point of diagnosis, he was too old for any kind of treatment, and over the course of the last 3 years, 4 years, he slowly deteriorated, and he actually passed away last October. So it was because of Cahill, and because we identified the disease in Cahill, that it's a genetic disease, and the chances of Linda, my wife, and I, sharing that gene with our kids is 1 in 4. And we had a younger son, Kieran, who was immediately tested at that time. He was 9 months old, and it was identified in Kieran as well. So unlike Cahill, Kieran was young enough to be eligible for a trial treatment, a gene therapy treatment, which was in Milan in Italy. So just a couple of days, 3 days after we received the diagnosis for both boys, we had to pack our stuff and we moved to Milan in Italy to enroll in that trial. And we stayed there for 9 months for that gene therapy treatment. All the while, Cahill was deteriorating and very ill, but Kieran was in isolation in the hospital there. But thankfully, the gene therapy kind of worked for Kieran. He has some damage because of the disease. He has some nerve damage, and he wears splints, and he walks sort of kind of unsteadily, and he has a neuropathy. But he's doing really well, and he's stable at the moment. So that's down to the treatment that he received. So I suppose to say that was a difficult couple of years that we've endured, and through Cahill's illness would be an understatement. It wouldn't do it justice, really. And I'd echo some of the things that Anne and Julie both said in terms of sort of the lack of information and the lack of a community and the lack of sort of direction as to what to do once you're diagnosed. You're sort of cut loose, and thankfully we found our tribe also, as Anne put it, but it's an international tribe very much, and I suppose the group of people that attended the gene therapy came from all over the world, and the support from those people and from the wider group of rare disease organizations and the parents group here in Ireland, we've found great help in getting through our experience. So that's my family story, I suppose. But what that led me to, and it was shortly after we returned from Italy and kind of got over that part of what was going on, that I took an interest in the disease in general and work that was being done across the world in terms of research and that, and discovered that in Italy, our adopted country at that point, that newborn screening had undergone a massive transformation in recent years. They jumped from screening for just 4 diseases at birth using the heel prick test, you know, the little blood spot test that they do at birth. So they jumped from testing for 4 diseases up to 40 diseases. And that resulted in them identifying, you know, over 350 cases of those 40 diseases in their population in their first year, and has continued in that trend since. And that was driven by legislation that was brought in, and was a long campaign done by people like us over in Italy, fantastic people. But they basically introduced a law that said that any child born in Italy would have the right to be screened for a condition that has a valid treatment, that has a valid screening program, and that has an economic case for the treatment of the condition. And that the responsibility lay with the Italian government and their health system to identify those conditions. And every 2 years, they revise that same list. And if there are new conditions that should be included, that they're obliged to screen their citizens for those, because, you know, the outcome in all cases is far better if patients are identified early, and in some cases it can be life-saving, as it was with our boys or our boy Kieran, because of the gene therapy. So I came back here and I decided I would try and instigate a similar type of campaign here, and that was about 2 years ago. I came to looking for support from the Rare Disease Task Force and Rare Disease Ireland and other patient advocate groups, and did all the things that people do, and was on the radio and the newspapers, and got petitions signed, and it progressed pretty well in the beginning, and got to the minister, and several politicians were very supportive of it. And basically there's 2 elements to the campaign, and one was the legislation, and the other was, you know, the immediate revision of the list that we already have. We only screen for 8 conditions here in Ireland, and through doing the sums based on the Italian data, 1 in 1,750 births here in Ireland, one of those conditions would be identified, and that equates to 50 children in a year. So approximately 1 a week being born here in Ireland with a condition that, if they were born in Italy, it would be identified and treated. But here in Ireland, it's going missed, and it's costing lives. So Senator David Norris, the best one, he drafted up legislation, and this has progressed through the Senate. There's been 2 debates on it, and support across the board from the government and all parties for legislation. Now, it's not identical to the Italian version. I'm told that in the context of Irish law that we couldn't draft a law similar to theirs, but the legislation that they have drafted, and I hope will progress this year into the Dáil, states that the conditions determined by our National Screening Advisory Committee, that it would give a statutory sort of footing to that committee, and anything that that committee would decide should be screened for by law, it would be enforced. And so that just supports the notion of that the work of the National Screening Advisory Committee, you know, should be listened to and acted upon. The National Screening Advisory Committee didn't exist at the beginning of the campaign, and thanks to the political support that we gained, Simon Harris, I suppose, namely at the time, and also was part of the Scally report related to the cervical screening sort of scandal that any new screening programs in Ireland must have full, transparent and proper governance. So they first had to establish the National Screening Advisory Committee, which has been in place now for 18 months, and they've had several meetings, and they've looked at newborn screening. But in their wisdom, or their lack of wisdom or ambition, they haven't gone for the sort of radical expansion notion that the Italians have gone for, but they have reformed the application process. And I know they had a meeting this week only where they ratified that application process, and that application process will be open to all comers by the third quarter of this year. And so I suppose the stage is set in a way for patient groups and advocates and clinicians to apply for individual conditions to be assessed by that committee and included on our newborn screening panel that we do at birth. So all the while during this campaign, I had always stated that MLD, my boy's condition, was never part of the ask because it didn't have an approved therapy, and it was a trial therapy that Kieran attended, and it didn't have an approved screening process, which was just in development phase as a pilot. But since November of last year, the EMA approved the therapy that Kieran had, and that's off the back of 20 years of research and 10 years of clinical trials. So it's a very strong gene therapy sort of treatment, and it's approved now by the EMA. So although I was just disappointed with their sort of route, the route that the Screening Advisory Committee had taken, not to rapidly expand or be very ambitious, I suppose I take some consolation in the fact that now that the process is open for application, and also that MLD is now a very strong candidate for inclusion because the treatment is approved. The pilot screening process is not fully approved, but it's been ran now in Italy, in Germany, in Spain, and will be opened in a pilot kind of way in Manchester in the coming months. And that the treatment that we received in Milan, also they're establishing a treatment center in Manchester. So we have links to the hospitals there, and I've been working in recent weeks to enroll sort of the help of clinicians who are interested in, well, metabolic consultants from Temple Street and the director of our national screening lab to do 3 things in relation to MLD. And number 1 is to begin a trial of the screening project, the screening process, which will be a research project and can be done outside of approval from the National Screening Advisory Committee, and can be led by clinicians, and they've committed to do so. So they'll begin to validate the screening process for MLD in Temple Street, I hope, this year. Also, in parallel to that, and the second thing is to make an official application to the National Screening Advisory Committee for the inclusion of MLD. And we can do that at the same time while the work is going on with the trial to validate the screening process. It can be considered by the screening committee as a candidate for inclusion. And the third thing is, just because the gene therapy treatment was approved by the EMA, it doesn't mean that we automatically approve it here in Ireland. And of course, there's a long and drawn out process there what will I call them now, the national, what is it, the National Centre for Pharmacoeconomics, NCPE process for approval of new therapies. So that has begun. That's been driven by the pharmaceutical company maybe, but there's a role there for the likes of myself as a family affected by the disease and other patient advocate groups who have promised to support it and make submissions to during that process to hopefully have the treatment, access to the treatment and remuneration for the treatment approved here in Ireland. And there's also another avenue that we can take, and we are taking at the same time as applying here in Ireland. We can also apply as the bloc country groups, the Benelux countries. You know, Ireland is part of that now, so it's Belgium and Luxembourg and Austria, I think, and Ireland. So they can approve access to treatments and purchase, you know, drugs through that sort of system. So whichever one of those is successful first, I hope that it will be adopted here in Ireland, and I hope that MLD can be sort of fully addressed. You know, the thing about it is Kieran was 9 months when he was treated, and he has damage because of the disease, but is stable and hope he will survive. But kids who are treated right from birth, who are identified very early, are completely unaffected, and they have full and happy lives as any normal person without the condition would. So basically, you know, the difference between treatment and not treatment is night and day. It's life and death, and you know, my two boys are an example of that. And I've been very passionate about advocating for initially the sort of radical change I was looking for, but unfortunately I'm probably going to have to roll over on that and accept what they have decided to go ahead with. But I will engage with it as best I can to have MLD fully accounted for and sort of addressed here in this country, so that, like Anne said, I also received, because I was all over the bloody papers and on the radio and things, if you Google MLD in Ireland, you know, I come up, and me and Cahill and our family story comes up, and so I get the calls, and there's no patient organization for MLD, and I'm not part of any organization. But I get the calls. I got 3 last year, and I got 1 this year already from versions of myself from a couple of years ago, desperate for help and guidance. And you know, at the moment, I've decided to focus on trying to eradicate that situation occurring. You know, we could set up a patient organization, and you know, there are ones that exist that are very helpful, and we always direct those people to them. There's not one here in Ireland, but rather than help the people who have to pick the pieces up, I'd rather ensure that that doesn't happen, and that those children can be saved. Because what I saw of Cahill's life, and we spent every second of it with him, and no human being deserves that sort of life, and that the nature of the illness is brutal and very cruel. So I wanted to just share that with you. It's my experience of a rare disease and living with a rare disease. I didn't go into, and I could, and it's graphic enough. But it's more a report on what's going on in the newborn screening world here in Ireland, and to raise awareness of that, and to invite patient organizations and anyone who is interested or has an interest in it, and to inform them that this progress has happened, and that the application process has been revised, and I hope refined, and I hope will make a clear path for applications into the future beginning this year, and we'll see an incremental increase in the diseases that are screened for here in Ireland, and that will save lives indefinitely into the future. And that is what I wanted to say. And I thank Suja and my other friends. I see their names all over the place popping up there for inviting me to share the story with them. And I hope it resonates with a few people and that they can focus their energy on it or do whatever they can to help it progress into the future.
Thank you, Les, for sharing your experiences and for the work that you've done to expand the newborn screening program. And as you said, there still is plenty of work to be done in that area. Okay, so we're going to move on to Aisling. So Aisling is our final speaker. And as I said before, Aisling is a representative of Rare Ireland. And she's going to discuss common and unique challenges that children and families experience while living with rare chromosomal disorders in Ireland. So I'll pass the floor to you, Aisling. Thank you.
Thanks a million. So as Emma said, I'm Aisling. I'm representing Laura, who is the co-founder of Rare Ireland. And today I'm just going to discuss some of the challenges which are faced by families living with rare diseases in Ireland today. So some of the challenges are, the first one would be inadequate information and reduced psychology services. So this would be one of the biggest challenges facing families living with rare diseases. And I will discuss more detail in one of the case studies later on in the presentation. We have long waiting times and difficulties in accessing genetics testing. So this is especially true if a child isn't displaying significant symptoms. In these cases, children are often said to have an intellectual delay. There's no support transitioning to new services. So when transitioning to adult services from school, there's no support to help with this. The child is not really considered or given preparation for the transition, and this can result in extreme anxiety or breakdown for the people involved. There's lack of knowledge among medical professionals. So every time we go into a doctor as a rare parent, we have to explain the condition and how it affects our children. Parents are constantly trying to educate medical professions on their child's condition. Respite and in-home support deficiencies. So there is a lack of funding for this and huge waiting lists. In some areas, there is no children's respite available at all, which means that some families are not getting any respite. And some families must wait until a child is 8 or 9 to access a service. And parents have to fight for things like nursing care for children that need care overnight. There is another gap between child and adult respite and more waiting lists. So sometimes families are offered home help, but then when they go to apply for it, they can't get it because there's no funding available at the time. There is no specialist care. So in an ideal world, we would have one specialist available to every child who understood how specific chromosomal abnormalities affect all aspects of each and every child. There would be a centre of excellence for rare conditions for people, where people can access the specialists that they need. There's no education among teachers and peers, which doesn't help with the understanding. Respite and in-home support deficiencies. So, sibling support. So there are very limited supports for siblings, children with rare conditions. So these siblings don't have a typical life. They've no supports to help them deal with the situation. And for them, when the reality of their situation versus their peers' situation becomes apparent, it can be very upsetting for them. And it's almost like a grieving process for them. So if parents were given the tools to help the siblings, it might actually make things easier for the siblings. And finally, reduced psychology services is a big issue. So there is limited to no child psychology services available in many areas, and this is an issue which I will discuss in a case study. So the first case study that I'm going to discuss is about inadequate information. So again, as I said, this is one of the biggest challenges facing families living with rare disease. So parents are given limited information post-diagnosis. So they find themselves having to do their own research to gather the knowledge they need to deal with their child's diagnosis. So without an Irish database of conditions, parents are still being directed to a UK organisation to make contact with other Irish families. It's very difficult to know the true impact of the condition without accurate and up-to-date information. Parents are relying on other parents for information, as it is often otherwise unavailable to them. Many of our children are diagnosed in late childhood or older, and parents have a long and lonely journey while they look for a diagnosis for their child. The sad reality is that this is heightened post-diagnosis, as they are given the name of a condition they've never heard of and little or no information to go with it. So Calvin is 7 years old. Calvin has a duplication syndrome at 7q11.23 duplication syndrome. Calvin has a significant speech and language delay. He also has a submucous cleft palate, which causes him further difficulty with speech, particularly his sounds and his pronunciation. So his submucous cleft palate was not mentioned in the SLT referral letter. So without the facts and adequate information, his SLT was unable to effectively help Calvin, and he couldn't reach his potential. His mother brought it to the attention of the SLT, and his plan was changed accordingly. Upon diagnosis, Calvin's parents were given downloaded information from the internet. The information didn't include new findings from more recent studies. Calvin was presenting with several characteristics that were not present in the literature that they were given. And after speaking to other parents of children with the same syndrome, they realized that those families were also reporting many of the same characteristics, which are not included in the literature. Calvin's family have never been offered genetic counselling. They met with a genetic consultant once when Calvin was an inpatient in hospital. They spoke to Calvin informally for approximately 10 minutes, and the parents received limited information. And this was the last contact that the parents had with the genetics department. Okay, so I believe, yes, okay, so I was just speaking about Calvin's surgeries. So Calvin has had several surgeries, and his duplication and potential complications are rarely in his file until they are presented by his mother. On one particular occasion, he was going for minor surgery, and his mother requested that an ECG and an echo be performed before he went under general anaesthetic. The reason for this was because she knew that due to his condition, he had an increased risk of having heart defects. So reluctantly, the tests were performed, and it was discovered that Calvin had 2 holes in his heart. They did go ahead with the surgery, but because of his mother's knowledge of his syndrome and her persistence to have the tests carried out, he had the appropriate team present in theatre should any complications arise. Due to his duplication, Calvin also has extra elastin genes, which affects his bowel. He underwent minor but invasive surgery to investigate the bowel issues and how they were presenting. His team were unaware of the extra elastin gene, as there was no condition-specific information available to them. After he was discharged, his mother brought it to the attention of the consultant, who informed her that had they known, they could have performed a different surgery, which would have greatly improved his quality of life. Calvin is still waiting on this surgery and remains incontinent as a result. Calvin also has many dental issues. Sorry, my slides have gone funny again. Calvin has many dental issues and attends a special needs dentist who was not made aware of the duplication and the dental issues associated with it. He has many teeth missing, and those that are present were discolored and decayed from the time they emerged. The lack of information presented to the dentist prompted him to think that the dental problems were as a result of poor oral hygiene and extended breastfeeding. Calvin's mother is deeply knowledgeable about his duplication, as she has dedicated much of her time researching it and how it impacts their family. She rarely meets a specialist who has knowledge of his condition and regularly finds herself reiterating the facts of his condition to the doctors and the therapists she meets. These facts are never recorded in the referral letters. And this is very common across the board with parents dealing with rare conditions. So if you want to just move on, please, Sucha. So the next case study is to just discuss psychology services. So this is Ella. Ella is age 7, and she has neurofibromatosis microdeletion syndrome. So Ella was discharged from early intervention team 2 years ago, and due to the gap in services went on a waiting list. Ella is still on a waiting list to be seen by the school age team. And during this waiting period, she has not been able to access any public therapies such as speech and language, occupational therapy, or psychology. Ella has significant challenging behaviour, as well as autism and ADHD. There's currently no psychologist in the area. The current situation is that when one psychologist is on leave for maternity or sick, etc., there's no instant cover for the position, resulting in months of a gap for services. The impact is that there's an extension to the waiting list that the child is already on. Ella's mother recently phoned the psychology service to see where I was on the waiting list, and she was told that it will be at least another 2 years, despite Ella's challenging behaviours. Ella's on medication prescribed to her by a psychiatrist. So the psychiatrist is only providing the medication and monitoring the medication dosage, but this is not being done in conjunction with psychology. So although the family have the medication for Ella, they have no psychology input to give them the tools that would help them to deal with Ella's challenging behaviour. Parents are ordinary men and women who don't have the qualifications and experience to deal with these behaviours. There are not enough people with the relevant qualifications available, which is resulting in a scarcity of services available for families. Across the board, people with chromosomal abnormalities, there are increased risks with mental health issues and anxiety. There's also an increased risk of schizophrenia and bipolar disorders. So without the input from psychology, there's a huge fear for families as to what the future holds, as these issues are not being dealt with when the children are young. If we don't have the tools to help children when they're small, how do we deal with an adult who has an intellectual disability along with these issues? So the only option for Ella's family is to pay for psychology services privately. However, this is not always an option for families. There may be other therapies that the families are also paying for. Parents are forced to pay for the services in the in-between periods while they're on the waiting lists. And it's incredibly expensive to obtain private assessments such as a psychology assessment. So parents will often make the difficult decision to put psychology therapy to the side to fulfill the other therapies that their child needs. So that's just a discussion on some of the challenges faced by our families with their children. And that concludes the presentation. So hopefully you found it informative. And thank you for listening and your time and attention.
Thank you, Aisling, for that input. That was really interesting and informative. So now what we're going to do is we're going to move on to a panel discussion, and this is going to be chaired by Avril Daly. Avril is the current Vice President of EURORDIS, which is a non-government patient-driven alliance of patient organisations representing 956 rare disease patient organisations in 73 countries. And she's also the CEO of Retina International. So Avril, I'll leave it to you to take over from here.
Thank you. Thank you very much, Emma, and thank you very much to the speakers. You know, it's so, you know, every time you hear the stories, it just crystallizes how much work there is to do, you know. So, you know, it's very, when you're an advocate in the rare disease space, you're always conscious of the progressive nature of these conditions and these diseases, you know, and, you know, we get to know from each other when we meet, you know, the realities of the lived experience, and we get an opportunity to share our experiences, you know, but a lot has changed, of course, since we all saw each other last, and I think we all saw each other last on Rare Disease Day, believe it or not, last year at the Oris, where we had a lovely celebration with all of our community. And it's sadly, we have lost many of the community since that time. And many have had further challenges to their conditions. And I suppose today we think of them when we are here today, and we wouldn't be here today if it wasn't for them. And I think their inspiration drives us forward at this time. You know, the ingenuity of this community is something that is really amazing, and the different tricks and the tools that are passed from parent to parent and generation to generation really keep us all going, and they help us through, you know, and improve our quality of life, and particularly technology, which is very important in this community. And a number of our speakers have spoken about reaching out and across cultures and borders, you know, to get the very basic information that they need. I think that's very important. You know, patients have played a very active role in advocating for very key policy achievements over the years in rare diseases, particularly in Europe. And I just wanted to go through some things first before I open up the questions to our panelists. You know, we had the adoption of the regulation of the orphan medicinal products in 1999. Then we had the adoption of the European Communication on Rare Diseases in 2008. And then in 2009, the EU Council recommendation on European action for rare diseases, out of which came the national plans. And then we had the adoption of the EU directive on patient rights for cross-border care in 2011. And then the promotion and maintenance of the EU, of keeping rare diseases as a public health priority within the EU. And of course, then we had our national plans, and we launched our own national plan here in Ireland in 2014. And then, of course, we have this International Rare Disease Day, which became International Rare Disease Week, you know, and a lot of progress has happened there. We have now our ERNs, which were really developed because how can you coordinate care for 6,000 to 8,000 rare diseases? You know, you have to have a structure in order to be able to do that. We have 24 ERNs. Currently, Ireland has 3, but I know through the second application, I think there'll be about potentially 19. Ireland will be represented in about 19. And, you know, they're highly specialized healthcare networks, you know, and they're set up to be a one-stop shop, you know, to improve outcomes for patients through improved access to high quality care, diagnosis, you know, and treatment, which are critically important. There are 300,000 Irish people living with a rare disease, and 80% of them are genetic. And I'm not even going to go into the reality of where we stand with genetic testing at this point. We'll discuss that in our panel discussion. You know, but you know, from a European, I just wanted to bring out some percentages. Some of you will have already heard me speak to this morning, but I think it's important to mention that in Europe, it still takes an average of 4 years to receive a diagnosis. 6% have access to treatments for their diseases, and 52% of patients and carers say that their disease has a severe or very severe impact on their daily life. So it's important to remember that. So we need new policies, new frameworks to drive ourselves forward as a community together. We had a discussion this morning about 8 new recommendations that will be the basis for policy actions as we move forward in Europe. Very sensible, very logical. You know, so a lot has been done. And yet, here we are. And as Anne Lawlor always says, what really matters is what happens back at the ranch, what happens here day to day in our daily lives. And what Julie, Les, Anne, and Aisling have really highlighted today is the complete and utter desperate situation people find themselves in to get something as basic as an access to a diagnosis. Patients need a diagnosis in order to have a prognosis, in order to have the supports and the care that they need. When you don't have that, you have all of the inappropriate interventions that have been outlined. You know, it's a really difficult thing to hear that, you know, in all of these policy actions that I've just read out, you know, in all of the work that's been done for 30 years in this space, you know, are we feeling it on the ground? So I thought today we might take some elements of the points that you all have made, and I might start with you, Anne. And Suja, just to say, you know, please do shout if there are questions come in, because I won't be able to see the chat box. So, you know, if there are questions, please do let me know. But I'm going to just ask the panelists a question each before we get to the audience questions. So, Anne, I just wanted to talk to you first about care pathways in general. Where are we in the context of transition? You know, you've always said to me, Avril, children don't grow out of their disease, they grow up with their disease. Where do we stand right now with that?
Where do we stand? Not in terms of rare diseases, in terms of any transition, I don't think we're standing on solid ground. We're, as an organization, Avril, we're very focused on this transition piece at the moment. But I've always held fast to the notion that if our children cannot navigate the transition piece themselves, what's the point in doing it? Because they won't comply, they won't go to their, as they become adults, they won't either have the capacity or the information that they need themselves to do this transition piece. So we're very focused on the transition piece at the moment. I'm absolutely delighted to say that we have a couple of superb clinicians who are working with us on this project and who are willing to take what we're saying as families, and we're really invested in listening to our young people with 22q, because the other thing I always say is, you know, they do grow up, they don't grow out of it, but I don't have the condition. I don't have 22q, so that's a piece of information that I miss. It's a piece of knowledge that I miss. So we're promoting the voice of our young people, and we're listening to them, and what we want to do is let what they're telling us inform policy and practice through this transition piece. And this transition piece for us has to go beyond medical care. It absolutely has to. And this is why, and it needs to be firmly embedded into this transition piece for children with these complex care conditions. What I would like to see is that, you know, what we develop would be applicable to all of these children, but it absolutely has to have the equal or more of actually more input maybe than the clinical pathway, because the clinical pathway is needed. It's all well and good, but it does not serve our children. It does not improve the quality of their lives, and it certainly does, and it certainly does not improve the quality of the life of the family, because these children, we cannot look at these children without looking at them in the context of their family. The Raindrop project that Suja has developed, I love the concept of it because it has a ripple. There's a ripple effect. So when you have a child with a condition, or you have a condition like Julie or yourself, a rare disease, there is a ripple effect. It affects everybody. We cannot look at our children, no more than we can look at one rare disease in isolation. We cannot look at our children in isolation. We have to look at everything with a bird's eye view and with a holistic approach.
I was going to say, I mean, I think it's important, and you know, looking at policy actions as we move forward. Of course, these are a framework for policy actions. It's not necessarily happening right now, but I think what's important to see is that is being considered. The fact that health is one piece, social care is enormous, education and access to employment, all of these things that are family. And actually, Anne, you're a person I know who's very internationally networked, and you have been for a very long time. You've had to, Les, you mentioned as well, you know, what your journey, I think, is very important to, I think, for people who are listening today who are new to this space. Because every year we have, unfortunately, people who are new to this space, right? They're having that whole shock to their system, which is the understanding that they have either a diagnosed or undiagnosed rare condition to deal with. You were able to, you know, find that trial, and you had to move very quickly. How would you, I suppose, advise anyone to do that, you know, to make that sort of that journey? How to start that journey is often very, very difficult for people to do. And the other thing I would ask you about as well, I have two questions for you, Les, I'm not letting you off easy, is this whole area of screening, early detection is critically important. As you say, it's linked to a treatment. I think us in the rare disease community, we only have 6% of people who have access to treatments. Does that mean that 94% of people don't have a care pathway? I think it does. So does that not mean, you know, this is value? And I know we use specific measurements and you know, to look at, you know, why we should screen, you know, we only screen in this case or that case. And, you know, I just wanted you to maybe just give us, you know, your thoughts on that. I know you have already, but just maybe some more thoughts that you have on newborn screening. So two questions: internationally networking and the newborn screening.
Yeah, well, the first question in terms of our situation, maybe in contrast to Julie and Anne and others, it was a very acute sort of diagnosis. You know, it was an emergency, and in that situation, I suppose, like any parent, you do all and everything that you can within your power to find out what you can do for your child. And we were just, you know, very unfortunate in one way with Cahill, but absolutely blessed in another way that there was that glimmer of hope for Kieran, and that's all it was at the time. You know, we were still delivered that terminal diagnosis for the two boys, but it came with a caveat that you might have a chance. And so that was the situation that was delivered to us. So onto the plane and over to Italy in a very delicate state, just to put it mildly. But they were very kind to us over there, and their expertise in relation to MLD is what really got us on track. Now, probably through no fault of their own, our own clinicians here in Ireland gave, you know, weak advice in relation to the nature of the disease and our prognosis, that we might have 6 to 12 months with Cahill. And in fact, when we went, you know, a few weeks later to Italy, they rubbished most of what we had been told, and they directed us very well, and we gained a much better understanding, and we continued to sort of take most of our advice in terms of symptom management from them because of their experience with dealing with the disease. And also on that trial program, every participant of the trial also had an older sibling
Yes,
that
this is the
unfortunately
fundamental point.
would have passed away. So, you know, that was the cost of it to the family. In each case, one child had to lose their life for the second child to be identified. And therein lies the problem, and therein lies the beauty of newborn screening as a solution for us. You know, that it had, you know, a lot of work has been done internationally in the States and in Italy, and as I said, it's been spread now. It's really encouraging. I only discovered in recent weeks that they're screening for MLD in Germany, in Hamburg, and they're starting in Manchester. So that's really progressing.
Yeah.
But what was your second question there? And
it was about the newborn. You've actually answered both questions there very efficiently.
Yeah.
Yes. Because really, you know, that's the point, which we see time and time again in the rare disease space, where because there isn't screening, because the elder child is not referred to a potential clinical trial, and we have to understand the value of clinical trials in this community is enormous. You know, and so you know, I think the work you're doing is important. And as a patient community, you know, we must be aware that we have actionable, we might not have treatments, but we have actionable conditions. And, you know, there's a lot that can be done with care pathways, you know, as opposed to just treatment. And before we go on there, I just want to bring Julie in on this as well, because in the context of policy, really, Julie, you know, your story is an extraordinary one, as are all of the stories in this rare disease space. You know, it's that whole, you know, diagnostic odyssey, the inappropriate interventions, the really the terrible consequences of those that you have to live with for the rest of your life. You have been involved in the ERNs and the ERN process. What hope do you think that the ERNs really have for people who are living with rare diseases or being diagnosed? And I suppose in the context, I'm just conscious there may be people on this call this morning or this afternoon who are new to this whole space. What do you think the hope really is for ERNs?
Well, I think, you know, like whenever you're diagnosed with a rare disease, you know, like there's always this thing of, oh, there's only one of you, or there's, you know, like 1 in 6,000 or whatever, or you're the only one in the county or whatever like that. And that all leads to terrible isolation. But for me, being involved in the ERNs, even before I got involved in the ERNs, because our consultants in Ireland, we have a few very good specialist consultants in Ireland in vasculitis. We've been involved in research projects. And then being involved in the ERN, then you start to learn about other research projects that are going on throughout Europe. So we're able to learn from other support groups within Europe about what they're doing, how they're dealing with issues that we're facing. They can learn from us. Mm-hmm. So it's nearly like there's a big pool of information there, and everybody has access to it, and everybody can share the information. It means that we're not reinventing the wheel so much.
Yes, yes.
And it increases our voice. We have a louder voice, and we have a voice that may impact on policy. at European level, which will filter down. But also we can let our local communities know, like we can let people back at the ranch know what's happening out there, because before I got involved in any of this, I, like that terrible sense of isolation and thinking, this is rare, nobody's going to know about this, and things like that. But actually there are pockets of work going on in different places, and it may not be in your area, but you can learn from it. And like when you're living with a rare disease, whatever the rare disease is, I think there are an awful lot of common issues, and we can learn an awful lot from each other.
And it's the pooling of the resource. I mean, and it's finding that home for rare diseases is very important. And I suppose we hope as well that in the context of ERNs, a rising tide lifts all boats, that if we are in a situation where we're networked to Europe, that our standards will have to improve. I know many healthcare professionals that would be delighted to hear that themselves, who have been advocating for this, for a long time, for some very basic services that hopefully the ERNs will provide. But I wanted to move to I think Laura has joined us. Is it Laura's here now?
Yes,
So,
sorry, Avril, there is a question. It's not just about a question. It's kind of more like a comment.
okay.
It's coming from, I think, is Lindsay Walsh. So as she mentioning here, as Anne said, that conditions such as autism spectrum disorders, ADHD, these individuals are not getting access to genetic testing, but may also have a genetic rare diseases. And as such potentially skewing maybe the actual true figure of rare diseases. I think also older individual living with intellectual disability, etc., who didn't have access to the near genetic test. So as it didn't exist at the time. So she's trying to say there is not enough genetic testing, and actually we have some figure at the moment we have 300,000 people in Ireland living with rare diseases. But if you test the people living with other intellectual disability, ADHD, autism, there will be more than what we expect. So sorry, Avril, I may leave that with you.
It's an important point, and actually it was something that I was going to move to Laura on. I think what was really interesting in the presentation that Aisling gave is, what you hear all of the time, all of the different services that are needed in order to be able to treat a child with a number of different conditions, a number of different symptoms, talked about the dental health, the mental health, the psychological supports. And so much of the burden is placed on the family to find the answers. But also, one of the things that's very important to mention, and you mentioned it as well, Julie, in your talk, is, this really affects the whole family. In your experience with Rare Ireland, I mean, you're dealing with parents all of the time, many parents, different conditions, but the main issues remain the same. If the decision makers were here right now, Laura, if they were here and they said, well, give me your top 3 things that you need for your community, what would be top of the list for you?
Like Aisling mentioned in the presentation today, the information is a huge thing. The access to genetic testing. If you don't have an excellent pediatrician, you're not going to get the testing done. We're very lucky that we had an excellent pediatrician. Other than that, we would never have gotten diagnosed. Looking at the family as a whole, in my personal experience, our family isn't looked at. The needs of our daughter is looked at. And we get because she only has moderate intellectual disability, we get everything is based on her needs and her intellectual disability. So our family gets very little because her needs aren't severe enough, and they don't look at there's 2 other children in the house as well. I suppose the psychology care as well, the psychological care is huge. Children are falling through the gaps every day with psychology. families in general are falling through the gaps with psychology.
And Laura, can I ask you a question? I think that's probably quite relevant to where we are right now in the world. Let's just say with the whole COVID situation, you know, there's been studies and there's been surveys and there's been this figure and that figure. How has COVID affected the care and treatment of the children, but also the families? I mean, what has been, you know, what has it been like, you know, just straight from your own experience? It would be nice to hear.
It's had a huge impact. You know, services have stopped. In our case, we haven't had psychology in over 10 years, but other families who are used to having different services, they've had no help whatsoever. The families who need home nursing care, that came to a halt altogether because they couldn't be allowing nurse and staff into the house. Everything was done over the phone. I mean, there's only a certain amount you can explain to somebody over the phone when they can't see your child. So it definitely has had a huge impact, and on the mental health of parents, which hasn't been supported either.
And mental health is an issue that's come up right across the board here.
Yeah,
everybody has mentioned mental health and well-being. Yeah, and you know, I might come back to you on that, Julie, actually, because you know you mentioned it very strongly in your talk. You know, the data issue. You know, the patient journey.
Yeah. Yes.
The value of that journey.
Mm-hmm. I think, like, I suppose hindsight is a wonderful thing. And if I look back on my journey before I was diagnosed, there were so many glaring things there that would kind of say, this is an autoimmune thing, you know. And I think because I was attending different consultants with different symptoms, there was no joined up thinking. And unfortunately for my condition, it's really like a jigsaw to get that diagnosis. There's no definitive diagnostic test. So it's like a jigsaw, but it's really, the really important thing, I think, is getting all your medical team to talk to each other. And to, you know, like share information. Because at the moment what's happening is that it's, well, I suppose for me here in Northern Ireland, our records are now, you know, like there's some electronic records. So you're not having to be the person that's coming and saying, well, this is what they told me in nephrology, or this is what my blood results said. But I just think, you know, like that joined up thinking would save so much time and so much energy, you know, like it would definitely save so much time in diagnosis, so much time and access to effective treatment. It would avoid so many prolonged symptoms or damage. So, yeah.
And one question that I would put to all of you, really, I suppose, is that we hear a lot about building back better after COVID, and you know the way that we can learn, that the learnings from COVID, you know, can be applied. And one of the things that's coming out very strongly, not necessarily by the patients, but by everybody else, and I'm hearing a lot about it, and I'm just wondering what your thoughts are the idea of remote healthcare. You know, I mean, particularly, you know, Laura, I wonder in the context of young children with rare diseases, you know, would you be comfortable being, you know, having a clinical appointment that was in this format or over the telephone, or would you prefer to have that face-to-face contact?
I would definitely prefer to have it face-to-face. It's much easier, you know, they can't get an overview of the child or the issues that you're dealing with over the phone or on a camera call. So I would definitely rather face-to-face.
Anyone
on
that topic, Avril, I would say I've been pushing for this for years, and we now have a pediatric clinic in Crumlin Hospital. And when we were in the process of kind of talking about that and looking to see it developed, I said to our fabulous clinician, you know, now that we have the clinic, I'd rather keep the kids out of it as much as possible. Why should children and families have to take time off work or school to travel from Galway or Sligo or Donegal? I'd like to see a blended approach. I'd like to see a network of excellence. I'd like to see electronic health records, virtual clinics, but also the face-to-face, because I think it has to be that way. There's a lot of waste. There's a lot of replicated kind of tests done. The electronic health records to me would be super. So it's like developing networks of excellence and shared care, so that the care is you know. I remember being in the clinic once, and a mum came in and she said, I have a fantastic pediatrician in Galway, and our clinician said, well, then let's share the care. And that's the way it should be, you know, collaborative type of thing. I know we're going, could I just, there's one thing I'm burning to say now, Avril, at the moment.
Go on.
Okay, I have to say this. We need to change the language. We need to get away from disability charity models around this. You know, this is not charity, and it really sticks in my craw that people like parents, like Laura and myself, had to set up charities. We had to set up charities and voluntary organizations, as if our lives are not stressful enough,
Yeah.
as if we're not dealing with enough, you know, to have to go through that very strict, stringent process of setting up a charity, having governance and all of that, which is in a job in itself. You know, but we're forced into that position, and then we're forced to describe our children in terms of deficits to get them the help that we need. We need to move away from this toxic kind of language, and you know, it's a health. These are human rights issues. They're social justice issues. You know, they're not. It's not charity and disability.
Yes, yeah, and I think it's a very important point to say that, you know, that your point about describing your children in their deficits is
it's awful. It's absolutely awful. Avril.
And you know, it's one of the things that you maybe Les and Julie, you might have, and I see Suja coming in there with a question, but just to say, you know, the whole idea of patient centricity and patient engagement, you know, do you still find that in certain quarters it's seen as, you know, it's not taken as seriously as it should, considering the value of the patient, of understanding the patient journey can bring to all parts of healthcare?
For the most part, Avril, it's tick box. There's a lot of talk, but you know, talk is easy. you know, and when all is said and done, there is a lot more said than done. There's a lot of talk about it, but it's still, in the main, I would see it as tick box. Yeah.
And Les, from your perspective, I mean, you've been involved in a very big campaign recently. I mean, we're all very familiar with it, and I think it's really provoked certainly people in this country to take action, because newborn screening, in the context of the national plans when we were developing them back in 2008, there was a sort of a sense of like, well, don't go near the newborn screening. You know, it's a complicated area, but you've managed to push very far ahead. And so how do you feel your voice was, you know, was listened to, or your ideas and thoughts acted upon?
I think I'm just going to share one while I speak here. One thing just to share, just to give people an idea. I don't know, can you see that? But it shows where Ireland lies in the table. But I think I had to force myself, as you'll probably agree, Avril and others who know me, upon the powers that be, to have them listen. And that was based on slides like this and other data and information, which is sort of irrefutable, like that we lie very close to the bottom in relation to newborn screening in Europe. And it's been a frustration that even in it's an issue across the board that the patients and the parents who are the experts, and in terms of MLD, like as parents, like we led the care of our children, and you talk about like remote appointments and things like that, you know, on occasion they would be fine for us because there was nothing that our pediatricians could add from looking at it. They listened to us. What's going on with Cathal? What are his symptoms? What do you think? Okay, we'll try that. And that's through our experience and our contact with all of the other families and parents that we've came across the world. But in terms of the patient input and having that voice, you'll recall that for the National Screening Advisory Committee, they advertised a post for a patient voice, and that was stated publicly around this day last year by Simon Harris in the Mansion House, that we'll have a patient voice on this committee. And they chose not to do that. They pulled that post. They didn't ever appointed that position. They put a public representative in place there. And my view on that is that nobody in that room, amongst the 15 or 16 people on that committee, nobody has my experience of life, of that experience through a disease for a child who could have been screened for a condition and end up, you know, through a brutal sort of disease pathway and finally pass away. You know, there's nobody who can speak from that perspective on that committee, and I think that's a view that's missing in that context. And I think that applies across the board, that not enough credit is given to us here as this panel and this group, and you know, the wider community of rare disease, you know, families, as our expertise and experience should be considered and taken very valuably by people who are making policy. I have a meeting with the minister tomorrow, and you know, there's several things that I want to very strongly put across to him.
And I've no doubt you will.
You know, it's because I know that I'm right, and I've been, you know, it's because it's done differently in other countries and done better in other countries, and there's no mystery surrounding that here in Ireland, that our healthcare, you know, leaves a lot to be desired, and there's much to be taken advantage from and learned from other countries and from people like us who are delivering that information back to them.
Absolutely. And Julie, from your perspective, I mean, you know, there's a benefit in going back to the data, you know, the understanding the burden of disease, and these technical terms, they're not the nicest terms to use, but you know, the burden of disease really, you know, highlights why it's important, you know, to create care pathways, why it's important to get access to therapies, because what is the cost of doing nothing? You know, the costs are enormous. Do you think that voice is being listened to? You know, and do you feel it's being taken seriously in the context of your own condition and the work that you're doing in rare diseases?
Yeah, I think we are lucky as a patient group, and that we do have close working relationship with some of the specialist consultants, and we do have access to European research projects and that. I think at the beginning it was very much like a tick box exercise. You know, like I will get the patient group on board here. We'll be able to say we've got the patient group on board, and you know, we mightn't even know what our name was being put to, kind of thing. But I think because we started asking more and more questions, and we started, you know, like I suppose it's getting confident in the knowledge that we have. Like I say to everybody, you know, like we live with the condition. Us and our families live with the condition. We have very specialist knowledge about how the different things affect us. And there's no, you know, like when we go into a doctor, there's no point in whenever the doctor says to you, well, how are you doing? And you saying grand, because they have no idea. They don't have a crystal ball. And you might think, well, why didn't they join up the dots? We have to keep reminding them that, you know, this is this is the way it's impacting me. And is there a solution? Can we try this? Can we try that? We need to educate ourselves as well, and then be confident in bringing that information forward. And I think whenever you are confident in bringing your information forward, bringing your data forward, showing that you have researched things, I think then you start getting, feel yourself that you are a respected member of the team, respect yourself, and then you'll get the respect then.
Suja has joined us here.
Sorry, Avril, I'm just looking at the time.
Yes.
I know there was not real questions, but I just want to say there are people congratulating all the panelists. I know there is one question from Vicky, but it's again about face-to-face consultation. Why she's saying about the pediatrician is often the gatekeeper. What made her pediatrician excellent? So it's not a question about, but I just want to highlight there are people commenting the panel discussion today. At the same time, I'm looking at the time because already we are over time. I know we could sit here all day and talk about the experience of living, which is something, I think which is something, a core concept of what we do in the healthcare setting, what we do in terms of service policy, practice. Everything has to be designed with the people, with their lived experience. That is something we could call co-production or co-design. That has to be come in play in Ireland, and even newborn screening program. And I really wanted to say thank you for this. And I just want to say to, sorry, I'm not the chair. So I just want to say to Avril, with the time, looking at the time, maybe I may pass over to you. Thank you.
Yeah, we might just wrap up there. As Suja said, we could talk all day, couldn't we? Because there's so many things. And, it's just interesting, hearing all the different perspectives, but also the commonalities. I mean, regardless of the conditions we have and that we represent, we're really dealing with a lot of the same things. And I suppose it's frustrating, to see that we're still, at that lack of access. We still have these massive issues with genetic testing. There is an opportunity to build back better, but the patient voice must be central to all of that. And, we're a small country, we're well networked, we know each other, and we have to find the ways to do that, and to do that for all of us, and for our future. It's extremely important. The patients are the experts, as you said there, Julie, and we can make things happen when we put our minds to it. So I was saying that last night actually on the Black Pearl for the EURORDIS awards, that I was thinking about the probe that went up to Mars and landed there. We've landed on Mars. We can't get people access to a diagnosis, and they called it perseverance. And I think perseverance is the word of the day for people with rare diseases. And we really should have had our nice hand logo on that probe, because I think it's a symbol of what can be done. And we're too often told what can't be done, but we can do a lot together. So I hope you all have a very nice rest of the day and rest of Rare Disease Week, and are able to celebrate Rare Disease Day in whatever way that you can. We can't be together. We had such a wonderful time last year, organised by Rare Ireland and Les, at the ORS. It was really fantastic. And, let's hope that next year we might be there again all together, and we'll be further along down the road. So thank you so much for your energy and for your commitment and for giving your stories today. And I hope that those in the audience have learned something, or maybe have triggered an idea. And I'm sure, Suja, everybody here is contactable if anybody has any questions or any ideas or wants to get in contact with any of the groups. So thank you very much for your time. And thank you, Suja, for all the work that you do. It's phenomenal. I think what's really great about the work that you do is you always keep the patient front and center. And so well done. And we look forward to more time together in the future. Thank you.
Thank you. Thank you, Avril, and thank you, everybody. And thank you, Justin, for hosting.
Yes.
His last three webinar he was hosting. Thank you so much, Justin, and
no
have
problem.
a good day.
And to all the attendees, I've just placed the link to our playlist, which will have the three webinars listed there. And this one will be on the playlist in the next week or so. Yeah. Okay. Thanks, guys.
Okay. Bye-bye.
Thank you very much.